So, if I told you that simply being born male is like one of the most dangerous pre-existing conditions on the planet, you might actually think I'm exaggerating.
Right. A lot of people do.
Right. You probably look around at all the structural advantages men hold globally and think, well, that just doesn't make any sense.
Exactly. But if we strip away all those assumptions and just look purely at the global epidemiological data, the numbers tell this really startling story about, survival, vulnerability, and early death.
Yeah. And conversely, if I told you that being born female means your body will routinely be excluded from the very clinical trials designed to save your life, just because your physiology is deemed, quote, too complicated, you might wonder how modern medicine functions at all.
Right. It's a profound paradox. I mean, we've built these global health systems that frequently misinterpret the very bodies they're meant to treat.
Because we just mix up biology and societal expectations, right?
Yeah, largely because of that. We fail to separate the two. When we look at health outcomes, like who gets sick, who recovers, who suffers, who dies, we are never just looking at a biological inevitability. We are looking at a collision.
A collision between the body you're born with and, like, the world you're forced to navigate.
Spot on.
Okay, so picture a strand of DNA. You have that classic iconic shape in your mind, right? The double helix. Two distinct strands twisting and spiraling around each other, connected by millions of these tiny little bridges.
You literally cannot pull them apart without breaking the whole structure.
Exactly. So today, we want you to take that image and apply it to something you experience every single day, which is your health. We're looking at the ultimate double helix of public health outcomes.
Yeah, the two intertwining strands.
Right. One strand is your biological sex. That's your physical hardware, your chromosomes, hormones, your reproductive anatomy. And the other strand intertwining with it is your socially constructed gender.
Which is basically the societal operating system you're running on.
Yeah. The roles, the expectations, the behaviors, and the physical spaces that your culture assigns to you simply because of that hardware.
And that metaphor is so crucial because, well, in clinical practice and public health policy, we constantly make the mistake of looking at only one strand.
Just focusing on the hardware.
Right.
Yeah.
If you only look at the hardware, the biology, you're missing half the structure. You fail to understand why certain diseases cluster in specific demographics.
But then if you only look at the software, the social gender norms, you're equally blind to fundamental physiological vulnerabilities.
Exactly. The reality of human health is that these two strands are constantly interacting, constantly communicating across those tiny bridges. And that interaction dictates your risk, your exposure, and your vulnerability to almost every disease on the planet.
So welcome to this custom-tailored deep dive. We are acting as your companions today as we unpack Chapter 10.2 of the Oxford Textbook of Global Public Health.
Authored by Sarah Payne and Leslie Doyle.
Right. And our mission today is very specific. Whether you're a medical student, a junior doctor, or a public health trainee, we're not just going to read you a list of statistics.
No, definitely not.
The goal is to build a robust, durable, conceptual framework in your mind. We're going to trace the pathway from risk to exposure to outcome to intervention and finally to system impact.
So by the end of this, you should really be able to master the reasoning behind public health decisions. You'll see the hidden forces shaping the data you look at in the clinic.
But before we jump into the raw mortality data, I think we need to establish a really critical piece of context here.
Yeah, intersectionality.
Right. Because the health gaps between men and women aren't uniform, are they?
Not at all. They are not some universal constant etched in stone. They shift, sometimes pretty violently, depending on where you look. We really have to view this through an intersectional lens.
And intersectionality is a term that gets thrown around a lot.
It does, but in epidemiology, it means something very specific. It means that gender and sex do not operate in a vacuum. They interact with socioeconomic status, with ethnicity, age, geographical location.
They all sort of mash together to produce entirely unique health risks.
Exactly. A wealthy female executive in Tokyo experiences the intersection of her sex and gender entirely differently than, say, a woman doing informal agricultural labor in rural Malawi.
Or a working-class male factory worker in the Russian Federation.
Right. You cannot separate the gender from the class or the sex from the geography.
Okay, let's unpack this. If the stage where we perform our gender matters that much, the best place to start seeing this double helix at work is at the very end of the human timeline.
Mortality.
Right, the ultimate crudest measure of public health. Who lives and who dies. It's definitive.
Yeah, a self-reported survey on a Tuesday can be subjective, but a death certificate is a globally tracked, undeniable outcome.
It's the hardest baseline we have.
It provides the starkest foundation for our analysis. Illness can be misdiagnosed or ignored, but mortality data, while not perfect everywhere, gives us a really solid place to start unpacking these disparities.
And that baseline has a massive, undeniable tilt to it. If we look globally at life expectancy at birth, out of all the nations tracked by the World Health Organization, there are only 3 countries in the entire world where men might expect to outlive women.
Just 3.
Just 3. Tonga, Tuvalu, and the Central African Republic. In 3 other countries, life expectancy is a dead tie. But in the remaining 187 countries, women live longer, period.
It's a near-universal female survival advantage.
Which is wild.
It is. But as epidemiologists, the fascinating part isn't just that the gap exists. It's how much the gap varies from region to region. Because, human biology doesn't change drastically when you cross a border.
Right. If the survival advantage was purely biological, the gap should be roughly the same globally.
Right. Exactly, but it's not. The variance tells us a story about systems and structures. Let's look at where the gap is really narrow. In low-income areas, particularly in sub-Saharan Africa, the female survival advantage almost vanishes entirely.
Wow.
Yeah. In Nigeria, women only have a 1-year advantage over men. In Sierra Leone, it's just a 2-year advantage.
So wait, if women have this built-in biological hardware advantage, which we'll definitely break down later, why does it suddenly disappear in those specific countries? Does poverty just, act as an equalizer of misery?
Poverty is the overarching condition, yes, but the mechanism is highly gendered. This is where the operating system overrides the hardware. The gap narrows in these regions because of weak health systems, poor nutrition, and systemic poverty.
Okay.
But specifically for women, it reflects devastatingly high rates of maternal mortality.
Oh, I see.
The biological advantage of being female is essentially wiped out by the systemic failure to provide safe childbirth. If a health system cannot support reproduction, being female becomes a lethal exposure.
That makes total sense.
You also see these highly compressed gaps in places like Bangladesh and Pakistan, where there's just a 2-year advantage, and Algeria with a 3-year advantage. It's a clear signal of women's low social status translating directly into a lack of healthcare access.
Okay, so severe poverty and lack of obstetric care compress the gap. But then we swing the pendulum to the exact opposite extreme. In specific high-income or transitional countries, the gap just explodes.
It really does.
And the starkest example in modern history, a true epidemiological earthquake, honestly, is the Russian Federation, along with several other countries formed after the breakup of the Soviet Union.
Yes, the 1990s and 2000s data there is incredible.
In 2009, the female life expectancy advantage in Russia was an astounding 12 years. Women lived 12 years longer than men. Estonia saw a 10-year gap. Sri Lanka, an 11-year gap.
And a 12-year gap at a population level is catastrophic. As you noted, human biology doesn't change when you cross the border into Russia. So we have to ask, what is the social strand of the helix doing there? What caused that chasm?
It has to be behavioral, right? Like a massive societal shift.
Exactly. It was a catastrophic deterioration of male health driven by socioeconomic collapse. Prior to the dissolution of the Soviet Union in 1991, male health was already slowly declining, but the transition to a market economy accelerated it massively.
Right.
Think about the psychological reality of that exact moment. You had millions of men whose entire identity, their, quote, hegemonic masculinity, was heavily tied to being a state provider.
Oh, wow.
They were guaranteed jobs, they had a defined role in the collective structure. Overnight, the industries collapsed, hyperinflation wiped out savings, and the social structures just evaporated.
The psychological void must have been immense.
It was. And how did men in that specific culture cope with the loss of their primary identity? They reacted with massive population-level health-destroying behaviors.
Like drinking.
Yes. There was a staggering spike in male alcohol consumption, specifically binge drinking of high-proof spirits, which triggered a whole cascade of liver cirrhosis, cardiovascular events, and alcohol-fueled fatal injuries and violence. The stress also drove suicide rates through the roof.
But wait, women face the exact same economic collapse.
Yeah.
I mean, the factories closed for them too. The hyperinflation hit their grocery budgets just as hard. Why didn't their life expectancy plummet 12 years?
Because their gendered social roles provided a completely different psychological anchor.
Oh, interesting.
While men lost their primary societal purpose, state, employment, women's roles were historically centered around holding the family together, managing the household, ensuring the children survived.
Right.
In a crisis, that role doesn't disappear. It intensifies. Women certainly suffered immense stress and hardship, but their coping mechanisms were vastly less self-destructive. Their software, their socially constructed gender role of the caregiver, essentially forced them to stay alive to keep the family functioning. The men lacked that secondary anchor.
It's a tragic but perfectly clear example of how gender roles dictate vulnerability during a macroeconomic crisis. The software literally killed millions of men.
It did.
But if we want to isolate the biological hardware, we have to look before society gets its hands on us, right? We have to trace this back to the beginning of the life course, to children under 5. Because the biology shows up incredibly early. Girls under 5 survive better than boys almost everywhere in the world.
Yes, the male biological vulnerability is a physiological baseline present right from conception. Fetal mortality deaths in the womb are significantly higher for male fetuses.
Really, just right off the bat.
Right off the bat. There are various biological theories for this, including the lack of genetic redundancy in the XY chromosome pairing compared to the XX, which makes male fetuses more susceptible to certain genetic anomalies.
Makes sense.
There are also differences in immunological interactions with the maternal system, and once born in early childhood, boys are generally more biologically fragile. They're more susceptible to infectious diseases and respiratory conditions.
I didn't realize it was that stark in infancy.
To give you the textbook data, the greatest excess risk for boys is in sub-Saharan Africa. In Guinea-Bissau, for instance, the under 5 mortality rate for boys is 174 per 1,000 live births, compared to 147 for girls. That differential is almost entirely the hardware at work.
But because humans are complicated, there's always an anomaly when social systems get involved, isn't there?
Always.
There are a few places where that biological baseline is completely inverted. 2 countries stand out in the data where girls under 5 actually die at higher rates than boys, India and the Solomon Islands.
And this brings us right back to our conceptual framework, risk, exposure, outcome. The male biological vulnerability in infancy is a risk baseline, but in certain cultures, gendered social practices create a massive unnatural exposure for girls.
Right.
Specifically, the strong preferential treatment of male children. In patriarchal societies where a son is viewed as economic security and a daughter is viewed as a financial liability, perhaps due to dowry systems, the allocation of resources shifts dramatically.
We're talking about literal survival resources here. Who gets the extra portion of protein? Who gets taken to the clinic when they have a fever?
Yep.
Who gets the warmest blanket?
Precisely. The preferential treatment of boys literally overpowers the biological baseline. The societal software actively degrades the female hardware until the mortality outcomes flip. It's a profound example of how social value dictates physical survival.
So we've mapped out who is dying and when. Now we need to look at what they're dying from. And the data here is really unintuitive if you only watch the news.
Oh, absolutely.
Because communicable diseases, your respiratory infections, tuberculosis, HIV, they actually kill men and women at relatively similar rates globally. About 26% of male deaths and 29% of female deaths are from communicable diseases.
And non-communicable diseases like heart disease and cancer are also fairly balanced globally.
Right, so the massive divergence, the glaring inequality in the mortality data comes down to one specific category: injuries and violence.
It is the defining wedge in global mortality data. Accidental and non-accidental injuries account for twice as many male deaths as female deaths globally. It's an overwhelming disparity.
Below the amount.
Yeah. When you drill down into homicide, particularly among younger age groups, men die at 4 times the rate of women. And in conflict situations, in active war zones, more than 90% of the direct, immediate deaths are men.
Okay, I am going to stop you right there because I think a lot of our listeners are running the exact same thought process I am right now.
Let's hear it.
Wait a minute. If 90% of conflict deaths are men, isn't that just an occupational hazard? It reflects the formal military structures, the drafts, and the informal paramilitaries, which structurally recruit or force men into service. That isn't necessarily a male gender vulnerability in the way we usually think about it, is it?
Yeah.
It's just the structural reality of who is handed a rifle.
You're entirely correct to point out that it is structural. The state mechanism of the military is the hazard. But we have to ask, why does the state mechanism exclusively target men for that hazard?
Yeah.
It's because the cultural performance of masculinity's strength, aggression, the protector role, the expendability of the male body for the state is embedded in the military structure. It's the ultimate systemic manifestation of gender roles.
Fair point. But if the men are dying on the battlefield, the mortality burden is clearly on them.
The direct mortality burden, yes. But if we apply our system's thinking, we cannot just stop at the bullet. What is the system impact of those conflicts on the women?
The ripple effects.
Exactly. The ripple effects of war hit civilian women the hardest, creating a delayed but massive mortality and morbidity wave. You have the sudden displacement of populations, the loss of agricultural land, the immediate plunge into severe poverty,
Right.
and crucially, the massive systemic increase in sexual violence used as a weapon of war. The men may die instantly on the battlefield, but the women are left in refugee populations facing malnutrition, infectious disease outbreaks, maternal mortality without any clinical support, and profound generational trauma.
The primary exposure is male, but the secondary exposure completely decimates female populations. It's the hidden mortality of conflict. The death certificate might say cholera in a refugee camp, but the actual cause of death was the systemic impact of the war that displaced her in the first place.
Right.
And speaking of heavily geographically isolated mortality, we have to return to maternal mortality. Because if we're building a framework of public health, this is the ultimate indicator of health system failure. In 2010, the textbook notes that more than 280,000 women died from complications of pregnancy and childbirth.
And we really must emphasize this for our medical audience. Maternal mortality is a uniquely modifiable cause of death. Unlike aging or certain aggressive cancers, maternal mortality is almost entirely preventable with basic systemic clinical interventions.
Hemorrhage, sepsis, eclampsia.
Yes, these are highly manageable with skilled attendants and basic resources. Yet the global disparity is shocking. In Chad, at the time of the data collection, the rate was 1,100 deaths per 100,000 live births. In Somalia, it was 1,000 per 100,000.
And contrast that with Australia, where the rate was 7 per 100,000, or Sweden, where it was 4.
That gap from 1,100 down to 4 is not a difference in human biology. A uterus in Chad functions the exact same as a uterus in Sweden. It is entirely a difference in the systemic provision of care.
Right.
In Sierra Leone, 3/5 of all births happen without skilled health personnel present. In Niger, only 11% of women receive skilled health care during childbirth.
Wow.
When a public health system fails to provide skilled birth attendants, clean facilities, and emergency obstetric care, it is taking a natural biological process, reproduction, and turning it into a lethal occupational hazard for women.
Mortality gives us the hard numbers, the definitive endpoints. But if mortality tells us who dies, morbidity tells us who suffers. We're shifting our focus now to investigate an old famous adage in public health. Women get sicker, but men die quicker.
It's a catchy phrase that you'll hear constantly in medical sociology, but as you might expect by now, it's a massive oversimplification.
Of course it is.
The gap between men's and women's health widens and narrows at different stages of life, and crucially, the types of illnesses they experience differ wildly.
Let's start with how people actually perceive their own bodies. Self-reported health. This is a purely subjective measure. You send out a survey to a population and simply ask, how is your health?
And the paradoxes in the global data immediately pop up.
Yeah. In places like the Russian Federation, China, France, and India, women are significantly more likely to report their health as bad or very bad. In Russia, nearly a quarter of all women say their health is bad, compared to only 13% of men.
Which is deeply counterintuitive, bordering on absurd, when you remember our earlier discussion. Russian men are dying 12 years earlier than Russian women from massive cardiovascular and traumatic events, yet they're sitting there checking the box that says their health is fine.
Exactly. And then you look at Finland, and more women report their health as good or excellent than men. In Australia, the US, and England, the self-reported data is basically equal between the sexes.
It's fascinating.
I like to think about self-reported health, like a car's check engine light on the dashboard. The physical sensor might trip, the light comes on, but different drivers interpret that light completely differently based on their knowledge of cars and, frankly, their willingness to deal with a mechanic.
That's a great way to put it.
One driver sees the light, senses a slight vibration in the steering wheel, realizes something is wrong, and drives straight to the garage. Another driver sees the light, ignores the grinding sound coming from the transmission, puts a piece of black electrical tape over the dashboard light, and just keeps driving until the engine literally seizes up and catches fire on the highway.
That is a brilliant analogy for symptom perception, and the epidemiological data backs it up flawlessly. Studies consistently show that when men report poor health on these surveys, it strongly predicts premature death. The check engine light means the engine is actually catastrophically failing.
Wow.
But when women report poor health, the correlation to premature death is much weaker.
Why is that? Are we just seeing a data artifact of women complaining more about minor aches?
No, it indicates profound gender differences in health literacy, symptom perception, and the social permission to be unwell. Women are, generally speaking, culturally trained to be more attuned to physical symptoms.
Right.
They interact with the healthcare system earlier in life due to reproductive health, giving them a higher baseline of health literacy. Furthermore, society culturally permits women to acknowledge vulnerability and pain.
Whereas men?
Men, heavily influenced by hegemonic masculinity, are culturally conditioned to ignore symptoms, to equate pain tolerance with strength, and to delay seeking help until a condition is utterly debilitating.
Put tape over the light.
Exactly. But there is a biological component to the morbidity, too. Women experience much higher rates of chronic, painful but non-fatal conditions like osteoarthritis, migraines, or autoimmune disorders. They feel sick, they're objectively sick, their quality of life is severely impacted, but the condition won't kill them immediately. They're managing chronic disability, whereas men are suffering acute, fatal events.
Which perfectly leads into how they interact with health services. If women are feeling the symptoms and recognizing the check engine light, are they going to the doctor? In the UK, the US, and Australia, the data is clear. Women consult healthcare professionals more often than men do, and they take more prescribed medication.
In high-income countries with accessible, relatively universal healthcare, yes. But we must apply our intersectional lens again. We cannot extrapolate the behavior of a woman in London to a woman in rural India.
Right.
In low-income settings, massive systemic barriers suppress female healthcare utilization, even when the morbidity burden is incredibly high. First, you have severe economic barriers. User fees at clinics disproportionately impact women, who often lack independent income or control over household finances. If she has to ask her husband for the money to go to the clinic, the threshold for seeking care becomes much higher.
And beyond money, there are literal physical barriers to movement.
Yes, cultural barriers. In many societies, strict norms require women to be chaperoned by a male relative to leave the house or travel to a clinic. This means a woman's access to healthcare depends entirely on a man's availability, his willingness to lose a day's wages to accompany her, and his belief that her symptoms warrant the trip.
That's a huge hurdle.
And finally, you have time poverty. Women in these settings bear a crushing double burden of agricultural labor and intense domestic caregiving, fetching water, gathering firewood, cooking, caring for children and the elderly. They literally have 0 disposable hours in the day to walk 10 miles to a distant rural health post. Their morbidity is invisible to the system because the system requires them to cross hurdles they cannot clear.
So if we want to truly understand morbidity on a global scale, we clearly can't just rely on clinic admission rates or self-reported surveys. We need a more objective way to measure suffering. This is where we introduce composite indicators.
These are the heavy hitters in global public health data.
The first one is Hale Healthy Life Expectancy. This takes your overall life expectancy, say, 80 years, and chops off the years at the end that you are expected to spend in poor health or disability.
And the numbers there are revealing. The global Hale is roughly 58 years for men and 62 years for women. Women have more healthy years. But here's the critical mathematical catch. Because their overall lifespan is so much longer than men's, women also end up spending a greater absolute number of years living with disability at the end of their lives.
Wow.
They live longer, but those final years are heavily burdened by chronic morbidity.
The other massive indicator, the one you'll see in every WHO report, is Delhi's disability-adjusted life years. This is a complex metric that tries to measure the years of healthy life lost to either premature death or to living with a disability. Globally, men account for about 55% of all dailies lost, and women account for 45%. So men carry a slightly higher total burden.
They do.
But the differentiation focus here is what truly matters. What specific diseases are stealing those years?
The types of dailies are starkly divided by gender. Men lose massive numbers of years to cardiovascular disease, alcohol and drug use disorders, and traumatic injuries from accidents and violence. Those are heavily male-dominated dailies.
Yeah.
Women, on the other hand, lose their years to maternal disorders, depression, anxiety, and nutritional deficiencies like severe anemia. To put a specific number on it, demonstrating the unique female burden reproductive-related dailies, which include maternal disorders, complications of childbirth, and specific reproductive cancers, make up about 5% of the total global health burden for women. For men, reproductive dailies are just 1%.
I want to pause on dailies for a second. We promised you that we would help you master public health reasoning, and part of being a good clinician or epidemiologist is critiquing the tools you use. Dailies are treated like the absolute gold standard in global health funding, but they have a massive fundamental blind spot, don't they?
They absolutely do, and it's a deeply gendered blind spot that skews global health priorities. Let's look at the mechanism of a daily. The framework calculates the value of a lost year of life primarily through an economic lens, the loss of productive, formal labor, or the direct economic cost of clinical care.
Right.
Because of this, it is terrible at measuring social suffering, invisible trauma, or the loss of unpaid domestic labor.
Give me a concrete example of what it misses.
The most glaring example is sexual violence. The profound, lifelong mental health trauma, the chronic pelvic pain, the social stigma, and the disruption of life caused by rape and sexual violence are severely undercounted by the dailies approach.
Wow.
The metric simply doesn't know how to weight the invisible suffering of a woman surviving with that trauma if she is still physically capable of surviving. If your primary global indicator is blind to the primary form of violence experienced by half the population, it will inevitably skew global funding. Millions of dollars will flow toward easily quantifiable, economically disruptive diseases, while the chronic trauma of gender-based violence remains radically underfunded.
That is a crucial systemic insight. We've looked at the mortality outcomes and morbidity suffering. Now we need to isolate the variables. To understand why these patterns exist, we must define the two intertwined strands of our double helix, sex versus gender. What is biological and what is social?
This distinction is paramount. Even in high-level biomedical literature and clinical settings, sex and gender are often incorrectly used interchangeably. They are distinctly different concepts, and conflating them leads to bad medicine.
Let's start with sex, the hardware. For a long time, medicine operated on the assumption that sex differences basically started and ended with the reproductive organs. If it wasn't a, quote, bikini medicine issue breast or reproductive organs, men and women were treated as physiologically identical.
Which is wild to think about now.
Totally. But in 1999, the Institute of Medicine set up a committee to look at this, and their conclusion was revolutionary in its simplicity. Sex matters. Every single cell in the human body has a sex.
It's genetic, biochemical, and physiological. We mentioned the fetal mortality earlier, the XY versus XX chromosome vulnerabilities. But let's look at the biochemical level. Hormones. Female sex hormones, specifically estrogen, have long been observed to protect premenopausal women against a range of conditions, most notably coronary heart disease.
How exactly does estrogen act as a shield? Like, what is the physiological mechanism?
The leading theories suggest estrogen works on multiple pathways. It appears to increase the flexibility and vasodilation of the female circulatory system, making high blood pressure less physically damaging to the endothelial lining of the blood vessels.
Okay, that makes sense.
It also significantly alters cholesterol profiles. Estrogen tends to increase the good HDL cholesterol and decrease the bad LDL cholesterol, slowing the buildup of arterial plaque.
But I'm reading the textbook notes here, and it cautions that the evidence on this biological shield is mixed and inconclusive. It's not a magical force field.
Precisely. We have to be careful with biological determinism. If the protection against heart disease was purely a function of circulating estrogen, then providing hormone replacement therapy HRT to women after menopause should perfectly preserve that cardiovascular protection for decades.
Right.
Does it? No. Large-scale clinical trials, like the Women's Health Initiative, show that HRT does not reliably protect against heart disease, and in certain formulations and age groups, might actually increase cardiovascular and stroke risk. Biology is complex, and the estrogen shield is only one piece of a much larger puzzle.
Let's look at another massive hardware difference, the immune system. This is fascinating.
The female immune system has to perform a biological miracle that the male immune system never encounters. It must be robust enough to fight off environmental pathogens, but it must be uniquely capable of immense adaptation and downregulation. Because during pregnancy, the female body must not attack and reject a growing fetus, which contains 50% foreign paternal DNA. If a woman's immune system operated exactly like a man's, it would recognize the fetus as a parasitic foreign body and destroy it.
It's like an organ transplant. The body has to be chemically suppressed to accept the new organ. But women's bodies do this naturally.
Exactly, but this hyperadaptability comes with a massive physiological cost. Because the female immune system is so complex and highly reactive, women are vastly more susceptible to autoimmune diseases like rheumatoid arthritis, multiple sclerosis, or lupus, where the body's defense system gets confused and attacks its own healthy tissues.
Wow.
Roughly 80% of all patients with autoimmune diseases are women. And yet, in a perfect demonstration of this mechanism, when women with these debilitating autoimmune conditions get pregnant, their symptoms sometimes go into complete remission. The pregnancy-induced immune suppression temporarily cures the autoimmune attack.
That is incredible. But that same immune downregulation during pregnancy must open the door to other threats, right? It makes them more vulnerable to communicable diseases.
Yes. The temporary immune suppression required to carry a child makes pregnant women prime targets for severe systemic infections. Malaria is the classic example. A woman who previously had acquired immunity to malaria in an endemic zone suddenly loses that protection during pregnancy, making her highly vulnerable to severe malarial anemia and parasitemia. This biological vulnerability is a major driver of maternal mortality worldwide.
And the hardware differences go all the way down to the DNA. This specific example from the textbook is critical. Women who smoke, and even women who don't smoke but are exposed to secondhand smoke or environmental toxins, have a higher risk of developing lung cancer than men at the exact same level of toxic exposure.
This comes down to the genetic level, specifically gene expression. Research indicates that the genes related to lung cancer susceptibility and the metabolism of carcinogens are expressed differently in women. This is highly likely due to the location of those expressed genes on the X chromosome. Okay.
Women have two X chromosomes, and while one is generally inactivated in each cell, the inactivation isn't always total, leading to different biochemical processing of toxins. This biological vulnerability dictates not just a higher overall risk per unit of exposure, but often results in a different type of lung cancer altogether, adenocarcinoma, which develops deeper in the periphery of the lungs.
So that is sex, the physical hardware, the chromosomes, the estrogen, the immune systems. Now let's look at gender, the software, the societal operating system. How do we precisely define it in a public health context?
Gender refers to the culturally ascribed roles, conventions, expectations, and physical spaces assigned to men and women. Unlike biological sex, which is largely fixed at birth and universally understood across human populations, gender is highly fluid. It changes dramatically over time across different cultures and even among different economic classes within the same city.
Crucially, as many modern sociologists and public health experts note, gender is not just something you are, it is something you do. It is performed daily. You perform your gender in how you dress, what jobs you accept, how loudly you speak, how much space you take up on a train, and how you treat your own body.
And society rewards certain performances and fiercely punishes others.
Exactly. The concept of hegemonic masculinity is central here. We touched on this earlier with the Russian life expectancy drop. Hegemonic masculinity refers to the idealized, privileged, dominant form of masculinity in a given society. It's the archetype of the real man.
Like tough breadwinner, that sort of thing.
Yes. In many Western and global contexts, this archetype is associated with physical toughness, financial provider status, emotional stoicism, aggression, and a high tolerance for risk. Performing this version of masculinity grants a man immense social and economic power over women and over non-conforming men. But, and this is the crux of public health, it carries lethal health risks for the men performing it. If the rules of your gender dictate that wearing a seatbelt, eating vegetables, or going to therapy are weak or unmanly, your performance will eventually kill you.
Okay, I think I have the two definitions locked in, but I have a fundamental question about how we apply them in the real world. Where is the line? If a 60-year-old woman presents at a rural clinic with severe bone-on-bone osteoarthritis in her knees, is that her biological sex? Maybe postmenopausal hormonal changes accelerating cartilage degradation? Or is it her gender? The fact that her society expected her to spend 40 years doing grueling, repetitive, domestic, manual labor scrubbing floors, carrying water that physically destroyed her joints.
You have just hit on the exact reason why the double helix metaphor is so vital. It is incredibly difficult to separate them in vivo. To solve this, the epidemiologists Nancy Krieger and Sally Zierler provided a brilliant, durable framework for understanding this entanglement. They split the interaction into two distinct pathways: the biological expression of gender and the gendered expression of biology.
Let's break those down because they sound similar but operate in opposite directions. First, the biological expression of gender.
This is how social roles literally, physically alter your cellular reality over time. Let's look at osteoporosis. In a society where the gender norms dictate that women should be delicate, graceful, and are actively discouraged from participating in rigorous weight-bearing sports during their youth, young girls will engage in significantly less physical exercise.
Okay.
The biological consequence of that social rule is that those girls will fail to develop high peak bone mass during their critical growth windows. Fast forward 40 years, and those women are vastly more susceptible to severe osteoporosis and life-threatening hip fractures. The societal software rewrote the physical hardware. The social rule became a biological reality.
Wow. And the reverse, the gendered expression of biology.
This is the darker side of the coin. This is when undeniable biological facts are weaponized to create discriminatory social rules and environments. Let's look at occupational hazards. Recognizing the biological fact that women have reproductive capacity, a patriarchal society creates a rule stating that women are too fragile to work in highly lucrative unionized industrial jobs, supposedly to protect their delicate biology or potential unborn children. Or, as we see constantly in medicine, women are systematically excluded from early-stage clinical medical trials because their menstrual cycles complicate the data. The biological reality of reproduction is used to justify social and economic exclusion. This exclusion limits women's earning power and their access to life-saving pharmaceuticals, which in turn degrades their overall health. The biology is used as an excuse to impose a harmful gender norm.
That framework biological expression of gender and gendered expression of biology is an absolute game changer for understanding public health data. With those tools in hand, we are shifting our focus to the structural determinants, the physical and economic environments where gender is performed, work, wealth, and violence.
Structural determinants dictate the daily lived experience. Let's start with where we spend most of our waking hours: occupational and domestic labor. The strict societal division of labor creates a highly gendered division of occupational risk and physiological stress.
If we look at the immediate, acute mortality risks, men are overwhelmingly employed in the most dangerous industries on Earth: construction, transport, emergency services, deep-sea fishing, mining. If a scaffolding collapses, if a transport truck rolls over on a highway, or if a mine shaft caves in, the casualty list is almost exclusively male.
Yes, the acute catastrophic trauma risk is heavily skewed male. The societal expectation that men do the heavy, dangerous lifting puts them directly in the path of kinetic energy. But women face a completely different, insidious structural hazard: the double burden. Over the last 50 years, women have entered the paid formal workforce in massive numbers globally. But society did not simultaneously relieve them of their historical software programming. They retain the primary, often sole, responsibility for unpaid domestic labor. Data from the UK, which is a high-income nation, shows that women still spend, on average, twice as many hours per day as men doing unpaid housework and childcare.
And let's be clear, we aren't just talking about pushing a vacuum around on a Saturday morning. We are talking about the chronic stress of household management, the cognitive load.
Exactly. It's the invisible mental labor of planning meals, organizing doctor's appointments, managing school schedules, and sustaining the emotional health of a family. This dual burden, working a formal shift and then coming home to work a domestic shift, places immense chronic physiological stress on women. It elevates baseline cortisol levels, disrupts sleep architecture, and is a primary driver of the higher rates of female anxiety and depressive disorders we see globally.
That makes so much sense.
Furthermore, when women do enter industrial or manual jobs, they face hidden physical risks because of the male default world.
What do you mean by the male default world?
Look at ergonomics. Industrial workstations, assembly lines, power tools, and even the dimensions of safety equipment are predominantly designed based on male anthropometric data. They're built for male height, male arm reach, and male grip strength.
Oh.
When a woman operates machinery designed for a man's body, she is forced to overextend, overgrip, and utilize incorrect biomechanics for 8 hours a day. Consequently, women suffer vastly higher rates of repetitive strain injuries, carpal tunnel syndrome, and chronic musculoskeletal pain in the workplace.
It's the physical environment actively working against their biology. Let's talk about the ultimate structural determinant: wealth and poverty, because poverty compounds every other vulnerability. Women face significantly higher poverty risks globally. They are disproportionately pushed into the informal economy, street vending, domestic work, where there are no labor protections, no sick leave, and no pensions.
They systematically receive lower wages for the same work.
Right. And critically, even when they do earn money, in many patriarchal structures, they don't control the household finances. This economic vulnerability becomes terrifyingly acute in old age. Because of the mortality gap, women outlive their partners, but they enter their senior years with vastly fewer accumulated financial resources.
Poverty is the great amplifier of disease. But perhaps the most visceral, immediate structural determinant we must discuss is violence exposure.
And here we must issue a brief, important note for you, our listener. Just as a quick note for you listening, as we discuss these dynamics of violence and gender roles, we are strictly examining the epidemiological data from the Oxford textbook. We aren't taking sides, engaging in political debate, or endorsing any ideology here. We're simply mapping the reality of the source material to help you understand the clinical presentations you will see in practice.
And epidemiologically, the landscape of violence is violently divided by gender. Both men and women are at high risk of interpersonal violence globally, but the source, the mechanism, and the location of that violence differ completely. Let's look at the spatial domains. Men are primarily killed in the public domain.
The street.
They are killed on the street, in bars, or on battlefields. They are overwhelmingly killed by strangers, casual acquaintances, or rival groups. The violence is frequently related to criminal activity, gang structures, or performative masculine disputes over respect and territory.
Whereas the most dangerous place for a woman is often her own living room.
Yes, women are overwhelmingly killed in the private domain. They are killed in the home, by close family members, and specifically by intimate partners, husbands, and boyfriends. The violence they face is not a random public encounter. It is deeply intimate, sustained, and structural. Furthermore, women face the unique, pervasive structural threat of widespread sexual violence, both in domestic settings and, as we discussed, systematically in conflict zones, which, going back to our daily discussion, leaves a massive legacy of invisible trauma, unwanted pregnancy, and sexually transmitted infections that ripples across a woman's entire lifetime.
I think it's also important to note, based on the text, that sexual violence against men does occur.
It absolutely does, particularly in the context of warfare, prison systems, and institutional abuse. And it is severely under-researched and underreported because the experience of being sexually victimized violently conflicts with the societal expectations of hegemonic masculinity. The idea that a man must always be strong and dominant male survivors face catastrophic societal stigma. This prevents them from seeking mental health support, leading to profound, untreated trauma and high rates of suicide.
The public versus private nature of the violence is so revealing. It shows how the physical spaces society assigns to us, the street versus the home, dictate the unique threats we face. Which brings us to the next crucial step in our framework, doing gender behavior and risk. We know the environment is structured differently. We know the hardware is different. So what does this all mean for daily habits? How do people actively perform their gender through their health behaviors?
To frame this, we can look back to John Grant, a pioneer of demography in the 17th century. He was one of the first to look at population data and observe the mortality gap between the sexes. Over 300 years ago, he wrote, "Men, being more intemperate than women, die as much by reason of their vices as women do by the infirmity of their sex."
He nailed the behavioral gap 3 centuries before modern epidemiology. What he called vices, we call the performance of masculinity. Let's look at the most obvious vice: smoking. Globally, tobacco use is a massive male-dominated epidemic. The contrast in some nations is staggering. In Malaysia, 53% of adult men smoke, compared to less than 3% of women. In Bangladesh, it's 46% of men and roughly 2% of women.
In those specific cultures, smoking is deeply tied to the performance of masculine identity. It signals adulthood, independence, and social bonding among men. Conversely, female smoking is highly stigmatized. It is viewed as improper or deviant. But watch how fluid gender norms are and how behavior shifts when the rules change. In high-income, more egalitarian nations like Norway and Sweden, the societal stigma on female smoking dropped decades ago.
And the tobacco companies saw an opportunity.
Exactly. The tobacco industry recognized an untapped market and relentlessly targeted women with liberation and weight loss marketing campaigns. Today, in those countries, the smoking rates are essentially equalized between men and women. The biological vulnerability didn't change, the gender norms shifted, and the fatal behavior followed.
Alcohol follows a very similar, though culturally stickier pattern. Being an abstainer, someone who never drinks, is a predominantly female trait globally. In the Philippines, for example, women are 3 times more likely to be lifelong abstainers than men. And when people do drink, the volume and style of consumption are highly gendered. Binge drinking, the heavy, episodic consumption of toxic amounts of alcohol, is overwhelmingly a male behavior. In Ireland, Nearly half of all men report regular binge drinking, compared to 14% of women.
And that binge drinking ties directly back to our mortality data. The massive alcohol intake fuels the public street violence, the fatal road traffic accidents, and the high male injury dailies. Alcohol is a structural pillar of performing masculinity in many cultures. In fact, according to WHO data, there is only one country on the entire planet where female per capita alcohol consumption is historically higher than male consumption, Ecuador. Everywhere else, men drink more and they die more from it.
Let's move from what we drink to what we eat. Diet, energy expenditure, and physical activity. In high-income countries, we see a really fascinating, counterintuitive divergence in the data called the obesity paradox.
Yes, in places like England, the US, and Australia, if you look at the overweight category, which is defined as a body mass index, or BMI, between 25 and 30 men dominate the statistics. Men are significantly more likely to be overweight. But if you push further along the curve to the obese category, a BMI over 30 women suddenly take the lead.
Why does the prevalence flip like that? What is the mechanism driving men to be overweight but pushing women into clinical obesity?
It connects to a complex web of diet, physical activity, and poverty. Men in high-income countries consistently report diets lower in fruits and vegetables and much higher in red meat and processed foods. Again, meat consumption is often culturally ingrained as a masculine dietary preference. But men also report higher levels of leisure time, physical activity, or sports, which keeps a portion of them hovering in the overweight category rather than crossing into obesity.
And the women?
Women, conversely, are often subjected to massive time poverty due to the double burden we discussed. When you are managing a full-time job and all the childcare, there is literally no time for sustained leisure physical activity. Furthermore, poverty strongly and independently correlates with severe obesity in high-income nations due to the low cost of calorie-dense, nutrient-poor processed food. And as we established, women disproportionately bear the brunt of poverty, especially as they age.
That makes logical sense in a high-income environment. But the most shocking example of physical activity, diet, and gender norms comes from low-income settings.
Yeah.
You flag this in your notes as the energy trap, and it is a terrifying example of systems-level thinking gone completely wrong.
It is a profound public health failure driven entirely by gender-blind policymaking. In many low-income countries, well-meaning economic development policies aim to lift rural families out of poverty. The intervention was to encourage women to take on more intensive, formal, agricultural, labor-growing cash crops, managing micro-farming operations.
On paper, in a boardroom in Geneva, that sounds fantastic. Empower women with formal work, increase household income, reduce poverty.
On paper, it is a perfect economic intervention, but the policymakers only looked at the economics. They completely ignored the software of gender. When a woman transitions from domestic chores to hard, day-long agricultural labor, her physical caloric expenditure skyrockets. She might be burning an extra 1,000 calories a day. But the cultural gender norms within the household dictate food distribution. In highly patriarchal structures, the men and the boys receive the largest portions of the food, particularly the high-protein items like meat or dairy, regardless of who did the farming.
Thus the energy trap.
Exactly, as brilliantly outlined by researchers Jackson and Palmer-Jones. The women are doing massive amounts of high-energy work, but the patriarchal food allocation rules mean they receive insufficient caloric and nutritional intake. They are literally starving themselves to work the land. This chronic, severe energy deficit devastates their immune systems, leads to profound anemia, and results in catastrophic maternal and fetal health outcomes. A macroeconomic policy designed to improve the lives of women ended up physically destroying their health because the policymakers failed to account for who actually gets to eat the food at the dinner table.
That is just a devastating reality check for anyone designing public health interventions. You cannot ignore the cultural operating system. Let's look at one more behavioral factor before we transition to specific clinical pathologies, health-seeking behavior. We touched on this with the check engine light analogy, but the textbook features a quote from a male patient that sums it up perfectly. He states simply, "I don't go to the doctor unless something scares the hell out of me."
That quote is the distilled essence of masculine health behavior. For many men seeking preventative care, admitting physical vulnerability or going to a clinic for a non-acute issue is viewed as fundamentally unmasculine. It violates the rule of stoicism. This behavioral delay, the refusal to seek help until the pain is terrifying, is a primary driver of why men, when they finally do present to a physician, often have advanced, metastatic, or largely untreatable stages of chronic diseases like cancer or heart failure. The software prevents them from accessing the intervention until it's too late.
All right, we have built a solid foundation. We have our frameworks. We know the biological hardware and the societal software. We know the structural and environments and the behaviors. Now let's put on our clinician hats. We are going to apply the sex versus gender lens to specific clinical case studies. Let's start with the biggest killer globally, cardiovascular disease, or CHD.
Coronary heart disease accounts for roughly 1/10 of the total global burden of disease. And the epidemiological pattern is incredibly clear. Men die prematurely from it, while women die from it much later. In the UK, for example, the male mortality rate for CHD in the 45 to 54 age bracket is nearly 5 times higher than the female rate. Women with CHD die, on average, 10 years later than men.
So early on, the men suffer massive fatal heart attacks. Later on in life, the women do. Is this purely the estrogen shield we talked about earlier protecting women in midlife?
The hormonal estrogen shield is certainly part of the biological hypothesis, keeping female arteries more compliant. But it's not the whole story. The massive premature death rate in midlife men is heavily driven by the cumulative behavioral risk factors we just outlined. It's the decades of higher smoking rates, the heavy red meat diets, the chronic binge drinking, and the intense occupational stress. Men are actively, behaviorally exposing themselves to the hazards that trigger early atheroma plaque rupture and thrombosis.
What about cancer? We already talked about lung cancer and the specific biological vulnerability of the X chromosome. But the macro data shows lung cancer still kills roughly twice as many men globally.
Right. The absolute number of population-level deaths is driven by the sheer volume of the male-dominated behavior of smoking. In Thailand, the ratio of male to female lung cancer deaths is 2.3 to 1, simply because so many more Thai men smoke. But remember our discussion about the type of cancer. Women are biologically more vulnerable per cigarette smoked. And here is where the gendered marketing creates a lethal exposure.
Right, the light cigarettes.
Exactly. Because women were historically targeted with low tar or light cigarettes, operating under the false assumption that they were safer or more feminine, women naturally inhale more deeply to get the required nicotine hit. This deep compensatory inhalation pulls the toxic smoke further down into the peripheral alveoli of the lungs. This physical behavior, combined with their genetic X chromosome vulnerability, leads to a much higher risk of adenocarcinoma, a cancer that forms in the periphery of the lungs compared to the squamous cell carcinomas more frequently seen in men.
So the male risk is largely driven by behavioral volume. The female risk is a complex, lethal interaction of deceptive marketing, altered inhalation mechanics, and genetic vulnerability. Let's pivot to mental health. This is an area of medicine completely full of diagnostic landmines. If you look at the raw clinical data, women are heavily diagnosed with internalizing disorders, depression, and anxiety. Men are diagnosed with externalizing disorders, alcohol and drug abuse, and tragically, they commit suicide at vastly higher rates.
The global daily burden for mental illness is actually fairly evenly split between men and women, but the clinical presentation is entirely bifurcated by gender. And this forces us, as clinicians, to ask a highly critical question of the diagnostic data. Are men truly biologically less depressed than women? Or does our heavily gendered diagnostic system systematically fail to recognize male depression?
Given everything we've discussed about stoicism and symptom masking, I am betting on a massive system failure.
You would be right. Think about the classic textbook diagnostic criteria for depression. Crying, expressing feelings of worthlessness, articulating emotional pain, seeking emotional comfort. These behaviors directly conflict with the core tenets of hegemonic masculinity. A man performing his gender role cannot easily sit in a doctor's office and weep. So, men mask their depression. They self-medicate the psychic pain with high volumes of alcohol and drugs, or they express their deep internal distress through irritability, sudden anger, aggression, or reckless risk-taking.
And the medical system falls for the mask.
Exactly. The primary care physician or the psychiatric system sees the angry drinking man, diagnoses the classic male substance use disorder, and completely misses the underlying severe depression. They treat the symptom, the drinking, and miss the root cause. The tragic, ultimate endpoint of this misdiagnosis and lack of emotional vocabulary is the male suicide rate, which is twice as high as the female rate globally and often involves highly lethal means.
That brings us to infectious disease, HIV/AIDS. A totally different type of pathology. I always try to visualize HIV transmission like a breached fortress. Whether the virus successfully invades depends on two completely different variables: the physical strength of the city walls, which is the biology, and the diplomatic protocols of the guards at the gate, which is the social power dynamic. Both matter immensely.
That is a very apt visualization. Let's examine the physical walls first, the biological vulnerability. In heterosexual intercourse, women are physiologically vastly more vulnerable to HIV infection. The mucosal surface area of the vaginal wall is much larger than the exposed mucosal area on male anatomy, and crucially, it is exposed to a high volume of seminal fluid for a longer duration after intercourse. Furthermore, in situations where a woman is not fully aroused, which is common in non-consensual or culturally mandated sex, the lack of natural lubrication leads to microscopic tears in the mucosal lining. These microtears provide the virus direct, unimpeded entry points into the female bloodstream. Statistically, the transmission risk per single act is roughly 0.04% from female to male, but it jumps to 0.8% from male to female. That is a massive biological disadvantage for the woman.
But the guards at the gate, the social power to negotiate, is where the real disaster happens for women globally.
Exactly. A strong wall doesn't matter if you can't close the gate. Women frequently lack the social and economic power to negotiate safe sex or demand that their partners use condoms. They historically lack women-controlled prevention methods. Let's look at the epidemiological data from Asia over the past few decades. In 1990, women made up only 17% of the total HIV-positive population in the region. By 2007, that percentage had doubled to 35%.
And the textbook notes a devastating counterintuitive fact about those numbers. Most of those newly infected women had only ever had one sexual partner in their entire lives, their husband.
Yes. The infection surge was heavily driven by husbands engaging in extramarital sex, often with commercial sex workers, and then bringing the virus home to wives who had absolutely no economic or cultural power to refuse intercourse or demand condom use within the marriage. The male social vulnerability here is the performative expectation of having multiple sexual partners to prove virility and masculinity. He acts on the software, gets infected, and then, once infected, that same masculine stoicism prevents him from seeking antiretroviral treatment until he is severely ill and has already transmitted the virus.
It is the ultimate tragic example of the double helix in action. The biology makes the woman highly vulnerable to the virus, the gender norms make the man bring it to her, and the power imbalance prevents her from blocking it. Let's look at one final case study to lock in these concepts. Malaria. In 2010, roughly 660,000 people died from malaria, mostly children in sub-Saharan Africa, and the data from 2008 showed roughly 20,000 more male deaths than female deaths.
Yes, and that slight excess male mortality is almost entirely driven by the innate biological vulnerability of boys under 5 that we discussed earlier, the hardware vulnerability in infancy. But once you move past childhood and into adulthood, the risk matrix shifts entirely. Women face unique, severe biological risks because, as we established, the hyperadaptation of pregnancy suppresses their cell-mediated immunity, making them highly vulnerable to aggressive malarial parasites.
And their social roles increase their physical exposure to the mosquito vectors. Think about the daily routine. Women and girls are overwhelmingly the ones responsible for collecting water at dawn and dusk, precisely when the Anopheles mosquitoes are most active. They are doing the bulk of the agricultural labor near standing water.
And, critically, we have to look at the household economics of prevention. When a poor household has limited cash, they often lack the financial power to purchase insecticide-treated bed nets. If the household can only afford one bed net, patriarchal norms frequently dictate that the most valuable member of the family, the male head of the household, the primary wage earner, gets to sleep under it. The pregnant woman, who is biologically the most vulnerable to the disease, is left exposed. It perfectly illustrates how an infectious disease outcome is never just a simple math equation of a pathogen meeting a host. It is deeply dictated by who has to walk to the river at dusk and who holds the power to decide who gets to sleep under the protective net.
Which is the perfect conceptual transition into the final phase of our deep dive. Because eventually, after all the exposures and risks, these sick men and women have to enter a hospital or a clinic. What happens when they finally interact with the system? We have to examine what sociologists call the male default in medicine.
For decades, indeed for most of modern medical history, clinical research, drug trials, and diagnostic manuals have implicitly treated the average male body as the default human body. Women, particularly premenopausal women of childbearing age, were routinely, systematically excluded from early-phase pharmaceutical drug trials. This was partly out of a paternalistic fear of harming potential unknown pregnancies, but also largely because researchers openly complained that female hormonal fluctuations throughout the menstrual cycle complicated the baseline data.
Complicated the data, meaning women's bodies were deemed too complex and inconvenient to properly study. So the medical establishment just tested the drugs on a homogeneous group of men and then handed those same drugs to women, assuming they would work the same way.
Precisely. And the system impact of this assumption is medically profound and frequently dangerous. Women are not just smaller men. They metabolize pharmaceuticals entirely differently. Their baseline kidney filtration rates are different. Their percentage and distribution of body fat alters drug storage. And their liver enzymes process chemical compounds at different speeds. When a clinician prescribes a woman a drug dosage that was perfectly calibrated for the metabolism of a standard 70-kilogram male, they risk causing severe toxic adverse reactions or, conversely, a complete lack of therapeutic efficacy because the drug clears too quickly.
The textbook notes the National Institutes of Health, the NIH in the U.S., finally mandated the inclusion of women in federally funded clinical trials in 1994, which is shockingly recent. But the male default isn't just sitting in the pharmacy compounding data. It's deeply embedded in how doctors are trained to see illness. Let's look at symptom recognition.
We return to coronary heart disease for the clearest example. When a man has a myocardial infarction, a heart attack, he very frequently experiences the classic symptom profile: crushing central chest pain that radiates down the left arm. Why is that the classic textbook presentation? Because that symptom profile was written by male cardiologists observing predominantly male patients in male-dominated clinical trials.
But when a woman's arteries occlude and she has a heart attack,
She often presents with what the medical system labels atypical symptoms. She might experience severe, unexplained fatigue, shortness of breath, a cold sweat, nausea, or perhaps pain in the jaw or the upper back without any of the dramatic chest clutching. Because these atypical symptoms don't match the male default textbook criteria, primary care physicians or emergency room triage nurses frequently miss the diagnosis entirely. They dismiss the woman's symptoms as severe anxiety, a panic attack, or simple acid reflux. Because of this systemic misinterpretation, women are referred for life-saving cardiac catheterization tests far less often, and they are treated at much later, vastly more dangerous stages of the disease.
think of medical surveillance and diagnostic criteria as an early warning radar system. Our clinical radar has been heavily, historically calibrated to perfectly detect male frequencies for heart disease. The female signal is there, it's broadcasting a massive emergency, but because our radar isn't tuned to it, it just looks like background static on the screen, so it gets ignored until the system fails. And conversely, our psychiatric radar is heavily calibrated to female frequencies for depression crying, sadness, completely missing the male signal of anger and substance abuse.
That is an exceptional metaphor for systemic diagnostic failure. And this gender blindness extends beyond diagnostics into actual public health interventions. Take smoking cessation programs, which are a cornerstone of public health. For a long time, these programs were entirely gender blind. They treated a smoker simply as a generic smoker, assuming the pathway to quitting was identical.
But based on everything we've unpacked today, we know that is biologically and socially impossible.
Right. On the biological side, we know women metabolize nicotine differently, partly due to how the menstrual cycle interacts with nicotine clearance, meaning they often experience much more severe, erratic physical withdrawal symptoms than men. But more importantly, the psychological drivers, the software, are different. Men often smoke for social bonding, habit, or peer acceptance. Women, burdened by the chronic stress of the double burden and time poverty, much more frequently utilize smoking as a psychological coping mechanism for stress, and crucially, as a tool for weight management driven by intense societal pressures regarding female body image. If a public health cessation program just slaps a nicotine patch on a woman and doesn't account for these entirely different psychological stressors and biological clearance realities, it is virtually guaranteed to fail her.
It is a stunning, somewhat chilling realization that the very clinical systems and interventions built to heal us are deeply infected with the exact same biases and blind spots that made us sick in the first place.
And that realization leads us to a final provocative thought for you to carry forward into your clinical practice or your studies. We have spent this entire hour intricately dissecting the deeply entrenched binary of men and women. We've mapped the hardware of male and female biology and the software of masculine and feminine gender roles. But consider what happens when a patient walks into your clinic who doesn't fit neatly into this rigid binary. If our clinical trials, our diagnostic radars, our public health data collection, and our hospital wards are strictly and flexibly divided into male and female, how does the health system completely blind itself to the specific physiological and social vulnerabilities of transgender and non-binary individuals? The frameworks we've built today, Krieger and Zierler's dual expressions, the intersectional structural determinants, they are immensely powerful tools for understanding population health. But recognizing exactly where these binary frameworks fail, recognizing their hard edges and blind spots, is the absolute next frontier of global public health.
That is something profound to sit with, especially as medicine evolves. Now, before we wrap up, we promise to help you build a durable conceptual framework. And to make sure the foundations of what we've covered today are truly locked in, we're going to do a rapid recall session. I'm going to throw a scenario or a question at you. I want you to actively think of the answer, really test yourself, and I'll give you a beat to think before we give you the solution. Let's see how well you've mastered the concepts. Question 1. Globally, what is the predominant reason the life expectancy gap between men and women has narrowed in high-income countries in recent years? Take a second.
It is primarily driven by improvements in male health, specifically men adopting healthier behaviors like massive reductions in smoking rates. You can revisit the men, women, and mortality section of the text for more granular detail on this epidemiological trend.
Awesome. Question 2. Which major composite health indicator explicitly measures the economic value of years of disability-free life lost, but is heavily criticized by sociologists for failing to capture social suffering, such as the lifelong drama of sexual violence? Think about it.
Dailies, or disability-adjusted life years. Revisit the Composite Health Indicators section to consolidate your understanding of how this metric is calculated and where its blind spots lie.
Question 3. Let's test your system's thinking. A public health initiative encourages women in a low-income country to increase their formal agricultural labor to reduce household poverty. However, maternal health and infant birth weights sharply decline as a result. What specific systemic phenomenon does this describe? Got it.
This describes the energy trap. The increased caloric expenditure of the hard labor is not met with increased food allocation for the woman due to rigid patriarchal household dynamics dictating who gets to eat. Revisit the Doing Gender section for more on this policy failure.
Question 4. In the context of pulmonary oncology, women who smoke develop lung cancer at lower overall levels of tobacco exposure than men. This specific vulnerability is primarily attributed to what factor? Take a guess.
Biological sex differences, specifically related to differential gene expression on the X chromosome regarding how carcinogens are metabolized. Revisit the cancer case study section to review the mechanics of this vulnerability.
Question 5. Let's apply our conceptual framework. According to epidemiologists Krieger and Zierler, when women are systematically excluded from certain high-paying physical jobs because they are perceived as biologically weaker, a policy that subsequently reinforces social stereotypes about their fragility, this is an example of what concept. Think back to our two expressions.
The gendered expression of biology. Revisit the Gender and Health section to review this crucial bidirectional framework.
Final question, question 6. Why might the clinical incidence of coronary heart disease appear artificially lower in women in primary care triage settings, leading to dangerous delays in treatment? What's the reason?
Because women frequently present with symptoms considered atypical, such as profound fatigue, nausea, or jaw pain, compared to the male normative textbook standard of crushing chest pain. This mismatch leads to systemic diagnostic failure. Revisit the Gender Differences in the Quality of Care section.
Think about that double helix the next time you look at a patient chart or a public health data set. The biological hardware and the societal software, they're always intertwined. You simply cannot unsee it once you know it's there. Here are the details of this episode.
Women, Men, and Health.